Welcome back, everyone, from our break. We had a bit of a longer break and some adjustments to our agenda from earlier today, but we thank you all for still being here and present with us. And we hope that you are taking full advantage of the great features of our meeting website, discovering all of the great content that has been assembled. So next, we will have Augustus Boya, who is a program officer in the Center for HIV Prevention and Health Services, who will introduce our first panel discussion. Augustus, the floor is yours.
Thank you, Aaron. Thank you so much, everyone. Welcome to our panel discussion on achieving health equity for Latinx and foreign-born populations. We have a panel of providers who will offer their perspective on how our programs can improve HIV prevention and healthcare service delivery for these key vulnerable populations in Maryland. The objectives of this session are to summarize the current challenges of serving foreign-born population in the Center for HIV Prevention and Health Services funded program, to integrate health equity approaches in program implementation that speak to the needs of foreign-born populations in Maryland. And three, identify potential or component of internal organizational structure that enhances HIV medication support and prevention services delivered to foreign-born population. At this juncture, I will allow our panelists to introduce themselves with their names, position, and the agencies they serve. Following the introduction, we will proceed with our panel questions, our panelists. So we'll start with Tanya.
Good morning. My name is Tanya Munemo. I am a registered nurse and public health professional. I work with foreign-born clients, bringing the message of HIV and treatment and linkage to them. I work for the Patcha. I work with the Patcha Foundation in Montgomery and PG County here in the state of Maryland.
Thank you, Tanya. Troy?
Hello, everyone. My name is Troy Eckles. I'm a Community Engagement and Wellness Manager at the Latin American Youth Center, also known as the Maryland Multicultural Youth Center. My department oversees our HIV program.
Andrew?
Good morning, everyone. My name is Andre Bogle. I am with the Howard County Health Department. I serve as our program administrator for our HIV prevention support services, PrEP services, and DIS intervention services.
Thank you, Andre. And Samu?
Good morning, everyone. My name is Samukile Takavingofa. I work at Patcha Foundation on the HIV engagement program together with Tanya. And I am one of the lead navigators. And primarily my role is to link people living with HIV to most needed resources, which could be housing, healthcare, childcare, all those kind of things that bridge the gap between that population receiving or staying in care. Thank you.
Thank you. Thank you. We will just roll into our questions. Our first question to the panel is, tell us about the aspect of the program you work in that have proven successful to engage in foreign-born populations. What organizational structures and policies are in place that help to ensure that programs, activities are implemented in a manner that addresses health equity for this population? We'll start with Troy.
Thank you for the question. So one of the great things about working at the Latin American Youth Center is that we provide wraparound services that stream from food insecurity to childcare to adolescent education. So as we receive these families, and a lot of the families in our neighborhoods are foreign born, mostly Latin American and more recently Middle Eastern, we're able to provide them with all of those necessities, such as Pampers and food and all of the above. But in that moment, we get to ask, hey, are you interested in getting tested? In this, it's kind of like for them, it's most of the time it's, oh, I've never been tested, or I don't know anything about this. So it's an opportunity for us to educate and destigmatize it and all of the above.
Thank you, Troy. Tanya?
With our organization, the HIV engagement program, our target population is primarily African-born immigrants. And the biggest problem in this population is stigma. We haven't gotten to a point where HIV can be discussed freely. So the strategies that we use are trying to normalize it, bringing it to the communities, bring the message initially to where they are before we try to seek out who's HIV positive and needs linkage. So we provide information and we make sure that different cultures and languages are represented. And how we do that is we just create a level of comfort and talk about other conditions like HIV, like hypertension, diabetes, cholesterol, and then wrap around HIV message within that message to make it palatable to them. And we have diversity on our team. So when they see us, they see themselves in our team. So they feel comfortable engaging with us. Our navigators are the primary point persons. And when they're in the community and they know, oh, I can talk to somebody from Zimbabwe, or if they choose not to, talk to somebody from another country, should there be some privacy issues, as we always we always take HIPAA privacy into consideration. It's a very important part of HIV work, and wanting to create that trust with them, we really assure them that we will protect their information. Thank you.
Thank you, Tanya. Samu?
Yes, thank you, Tanya, for that. I will just add on to what Tanya has already said. So indeed, we have really tried to normalize HIV to make people feel like it's just a normal illness like any other disease. And one of the strategies that we really have seen giving us, success was, doing health fairs in community. So our health fairs are really one of those entry points where people come and, we provide services for any kind of, illnesses. It can be, like Tanya mentioned, hypertension, long-term illnesses, cancer, things like that. And when people come into that space and they know that, we are just talking about health, so to speak, they just come and they feel this is all about health. And in that health fair, we now have, our information there on HIV. We also make sure we have people testing for HIV in that space, and we just make them feel comfortable in that space. And also to add on to that, I think one of the other things has been to really tweak our language to what they understand. Because really, just the mention of HIV can literally scare some of our, especially Africans, away from just engaging. We say we work with people living with HIV, a person who just, no, they want to go away. But we now try to really normalize and, make them really comfortable, introduce games or things that can make them engage with us and see their understanding around HIV, and, correct some of the information they have and reward them for knowing something good about HIV through giveaways and, just making sure they're comfortable in that environment.
Under the parameters that I work under, HIV prevention and support services and STI in general, we've learned that, and as an immigrant myself, having some background on how the population that I'm from, how they respond to the healthcare system is indicative of how our clients here also operates and engage our systems. One of the things that we try to do as an organization in Harvard is to create a system that's universal in how core baseline services are delivered, so that everyone follows the same protocol in how we approach the business of healthcare and the public.
So the second question goes to Samukile, and it is, tell us about the current challenges for addressing the HIV prevention and care needs of Latinx, African, and other foreign-born population that you engage with.
Thank you, Pastor. So my name is Samukile. You can call me Samu. So some of the challenges that we have been experiencing, as has been mentioned before, is the stigma. And knowing that, talking about HIV in our communities, the communication bit, how do you communicate to people who know that or who feel that there's a lot of stigma attached to HIV? So it's been one of those big challenges, and really trying to understand communities that we work with and trying to be really culturally sensitive and, working with them in a way that they can literally relate to us, being culturally sensitive to their needs, specifically around, things that relate to their health, their sexuality, all those kind of discussions. They can be really, really taboo to talk about. So we really have been trying to get into the communities and trying to be culturally sensitive and using channels that they really, really understand in terms of communicating with them. So that's one of the challenges that we've been facing. And the other challenge that we've been facing is, bringing them to a point where they accept to be tested and find out what their status is. So coming to that place where we say, you know what, being tested does not mean there's something wrong with you, and really going with the U equals U, strategy that has come up that, we want you to just know. And we really want you to we treat everybody with the understanding that they're status neutral. So it doesn't really matter where you find yourself. And we are really trying to, hone in this information in the community, give a lot more information, and, trying by all means to be culturally sensitive to the people that we work with.
Yeah, and someone have a follow-up question. I know we have little time. There have been a lot of resources provided to address stigma, especially among foreign-born, but there seems to be a high level of stigma. What is contributing to the high level of stigma among foreign-born communities when it comes to HIV?
So it's mainly cultural beliefs that I really believe push, stigma, and the understanding that you people feel that, how do you get HIV? The messages that have gone out, it's a sexually transmitted disease mainly, and that information, when people get it, it's culturally embedded in them, linking it to things like promiscuity and, those kind of thought patterns that have always been like in the African communities. So it's more, I think, culturally embedded in the communities and the societies that we work in. And I think that's really the root cause that really perpetuates stigma.
Okay. Tanya, could you respond to question 2?
Thank you, Augustus. So the resources to address the needs of this target population seem to be scarce, even though they may seem to be out there. More outreach and education is needed. As someone alluded, that the reason why there's so much stigma is because the people are still stuck in old beliefs, and there is a need for education to bring them up to speed, if I may use that. And also just the knowledge of knowing the new treatments that are available. Many people in this target population do not know that somebody can actually come to a point of being undetectable and live like, their normal life and be productive. So HIV is still treated like, a death sentence. That's what brings about the stigma sometimes also. So if we educate the population and bring these resources to them and say, okay, it doesn't matter how you got it. Some people got it when they were born. It's not a fault of their own. But where do we go from here? And how do we prevent other people from getting it? So even the discussion around PrEP and PEP, that is almost unheard of. They don't know there's such things that exist. So those resources are lacking in this community. And other challenges are immigration status. I mean, they don't want to engage with healthcare providers because they think they'll be found out, and then it will jeopardize their life here. So we just have to reassure them that we really do not let any authorities know of their immigration status. That's not what we're there for. We are there to help them with their health and making them healthy. And then there's the lack of adequate insurance. Yes, they may get MADAP, they may get what they need to get HIV treatment, but there are other things that affect how healthy they can be living with HIV. If they don't have insurance to get that very important surgery that they need, they are not going to be healthy overall. So that is a challenge that goes back again to lack of resources. And then obviously there's language barriers. There's so many languages that come out of foreign-born populations. So trying to make sure you find all those languages can be challenging, but we still try. Thank you.
Thank you. Still talking about challenges you face in serving your population. Andrew and Troy, can you address that?
Absolutely. So the majority of the clients that we serve are Black and Latinx. While we do have a large Middle Eastern population, we have been unsuccessful in getting this population to come get tested. And I do believe that a large reason to that is communication. Our staff is approximately 85% bilingual, and bilingual being Spanish and English, but we have no one on staff that speaks Dari. So we have to basically partner with other community partners where they have one or two staff that are able to speak the language. But even then, we find that it is still very difficult to, even get them to explore the idea of testing. So now we're kind of, as a team, we're collaborating to see what we can do in the community to get this population to get tested.
Thank you.
As far as outreaching goes, we partner a lot. That's one of our biggest things is outreach, get out there to meet the community so that we can have these conversations. And we've come to realize that when you start talking about sexual health, when you start to talk about STIs and STDs, a lot of places will tell you, no, we don't want that at our event. That's not something that we feel is, kid friendly or, family friendly. This isn't that type of event. So it's definitely a lot more difficult than any other type of outreaching that we do. So we always have to go in and kind of tiptoe our way into all types of outreach events in order to be able to get people to, explore the idea. I will say that we have been successful in being able to kind of destigmatize the conversation in just ways that we approach it. So Tanya mentioned earlier that you can be born with HIV, and that's something that we always start with. We are like, all right, so when you think of diseases, what do you think? And a lot of them will say, oh, like gross or nasty or dirty or something like that. I'm like, all right, well, what if I told you that you can be born with something? Does that make that person dirty or nasty or any of those things? And they're like, oh, no, I guess not. So that kind of opens the door. And I'm like, all right, well, if you get a physical, yearly, what difference is it to go in and just have something checked if you know that you've had unprotected sex? And then it's just kind of, it knocks down that wall. so that we can get them to, just view testing different.
Thanks, Troy. And Andrea, you were in the middle of your presentation. We had technical issues, so you can summarize what you were saying and then address the question that has to do with challenges you face in serving your population.
Basically that we sometimes have challenges with outreaching based on just the premise that it is, a sexually transmitted disease or infection. And not everyone is okay with that being a conversation at their outreach events. And then we've had success in destigmatizing through just breaking it and meeting them where they are, breaking it down and meeting them where they are, and just kind of, addressing it at a novice level and then building on that.
Okay, great. Andrea?
To summarize on the first question and the second, I'd like to echo what my fellow panelists have said, because a lot of the issues are kind of pervasive across communities. And so addressing them, I think one needs to have at least a basic understanding of the communities.
Question number 3 has to do with elaborating on the challenges. So we would go straight into that. I want to follow up on the previous question about challenges. What are some of the strategies you have employed at your agency that have helped to address these barriers that have led to health outcomes for the population you serve? Also, in the event you do not have any answer, what resources have you tapped into to find potential solutions? I know in your previous answer, you did mention about some of the strategies, but I just want more detail and some of the resources you have tapped into. So I will ask Tanya to lead this.
Thank you, Augustus. So as for strategies, what we have found works best is inviting other organizations to complement what we're trying to do. We cannot work in a silo with this kind of work. So we have created strong relationships with other community organizations that are in the same space or that could complement, whether virtually or physically. So for instance, collaborating with organizations like HOPWA for housing, because housing is such a big challenge for our population. We see a lot of homelessness, and trying to get them into housing, it's linkage is what we do. But when we go to link them, it's very difficult to, get them into a shelter or into a place where they can be, housed. So HOPWA, which is for housing, crisis centers for that short-term shelter, and the Gilchrist Center for Immigration Services, because they deal with these kind of situations, not just specifically for people living with HIV. HIV just happens to be something that they have, but the social needs are the same as everybody else out there. So the Gilchrist Center out of Montgomery County has really been helpful, and also identifying within the community, say places of worship. This may be mosques, churches, where we partner with them and figure out how they can help us to support these clients. For instance, if it's food, we try to go to churches or mosques that serve culturally appropriate food, so that these people can continue to get something that's familiar with them. We have partnerships with like KPCI that does a food drive, providing such food. And also we encourage clients to get tested. I mean, we don't do testing, but we work with agencies that do testing. We either bring them onto our events, or we give our clients information on those, to go to those organizations. And we also encourage them when they go to their doctor to include that HIV test is the panel, like when they do the physical. Ask your doctor to do an HIV test as well. These are some of the strategies that we have tried to use, and also involving community leaders. Like there are a lot of international country organizations. So we tap into the power that they have within their communities, and we ask them to take this.
Tanya, I'm sorry that I interrupt. Your points are so important, but we have more meaning, so we want to hear from.
Okay, that's all right.
Yeah, please, thank you so much. Andrew, I will come back to you.
So what I'd like to say is, in the interest of time, I echo what our colleagues on the panel are saying. Like I said before, a lot of these issues are somewhat universal across jurisdiction. What's not universal is how we go about mitigating some of these circumstances, because population, how you deal with population varies from one set to another. One of the challenges that I think we all can agree that we come across with foreign-born and Latinx population are those customs. Those primary customs that we were brought up in our belief systems. And we were taught certain things as a young person, and we lived in a civilization as a young person with particular ideals. And now we're in a system that has resources that we can access, but our beliefs won't allow us to access those things. So as health workers, I think we have to become a jack of all trades. And what that does for you as a case manager is it allows you the flexibility to be able to talk to your clients about vast majority of different things, not necessarily in depth perception, but in a manner where you could introduce a particular core service to that person and address their overall health needs, not necessarily just the HIV needs. Because of stigma, I think you have to look at that holistic approach and pull all the other key components into it, so that it just doesn't seem like it's one thing that you're pushing. And that seems to help with the stigma part and the core belief in trying to re-educate this population on the facts of things and introduce them to new things, to lessen the blow of them not wanting to seek out services. And sometimes they don't know. So you have to go out and do those outreach activities, talk to those providers that provide those services to that population, let them know about the services you provide, and even go as far as have them bring you in to talk to their clients. That oftentimes translates into them taking that information back into their community and spreading that word. Because as we mostly know, word of mouth is a strong vehicle for healthcare, especially when we're dealing with ones who have cultural beliefs. And so once we get our social networking up with existing clients, they can take that back to their communities and bring our initiative forward.
Sorry to cut you off because of time.
Thank you.
Troy, do you want to throw in? There's any gap that you want?
Absolutely. Is this the question regarding strategy?
Strategy, and if there's no, you address that lengthily. Is there other resources that can be used to assist, especially non-documented immigrant that you are aware of that you can share?
So typically it's in this community, we let them come to us. It's not more of a situation where we go and try to find them. We'll be in places that we know that they will be present at. In most families throughout the pandemic, I think it was 40% of families someone lost a job. This was even higher in our immigrant families. So a lot of them are still reaching out for those, like I said before, wraparound resources such as food and all of the above. So being present in those places and kind of, having a sign or pulling people in to even have a small conversation with you has been one of the best strategies for us. We've also in outreaching events where it's like they have to go through and, get a signature from each table. It kind of forces them to at least, speak a little bit, and from there we take it from there. So just being able to get them at the table is ultimately the challenge, but also where we see most of our success.
Someone, do you want to throw anything in quick before we go to our last question? We only have 3 minutes.
Okay, just a quick one to add on what Tanya has said, and Troy as well. The other strategy that we have seen really working for us is enhancing our support for the people that we find who are living with HIV. We have really been hands-on in terms of the support that we give and the linkages. If it means we are going to be there with the client and make sure we help them fill out their forms that they need to fill out, if we need to link them to someone who, if it's language barrier, whatever it is that we need to do for the client, really, really enhancing that. And also we have really tried to create community in terms of just creating support groups for those who find themselves in that state, because most of the time they are out of community, so to speak. They have no people they can speak to regarding the experience they're having living with HIV and the challenges they face. So that's
all right. We will stop there with you. I'm sorry for keep interrupting. I just want to touch on every question. So our last question, which would go further in further detail during our breakout session, is many programs lack the staffing capacity to reach certain foreign-born populations. Based on your experience and knowledge, what recommendation do you have for other organizations to help them build a more comprehensive approach to serving this population? I will start with Andrea.
Yes, can you hear me
just
still?
give you 15 seconds each. 30 seconds each person.
Okay, can you hear me still?
Yeah, just go ahead.
Okay, great.
20 seconds, I'm sorry, we have less than that, yeah, 20 seconds.
Okay, so with the understanding that there is might be deficiency in staff and in able to reach out in a meaningful way to populations, I think one of the things that we have to always consider is who are the stakeholders in the community, that we could reach out to those stakeholders and get them up to speed on our core services that we're trying to get out in the public, and let them be the persons or the group to sell that point on our behalf. They know their people, and it's easiest for them to reach them on the level that they're able to reach them.
Thank you. Tanya? 20 seconds.
I echo what
15
Andrew
seconds,
said.
I'm sorry.
Yes, I do echo what Andrew said, and also utilize volunteers. People are willing to volunteer for such great causes. Thank you.
Is there anything that is missing that one person can just step in before we? Okay, then on behalf of our team, I just want to say thank you for your input. This was a very, very valuable conversation. I'm sorry because of time we could not go in further detail, but thank you. Next is our breakout section where we will go into further discussion about what was presented here. And I hope you can transition. I think Aaron communicated how you can transition to that. Again, thank you for your input. And right after the breakout session following this, we'll go for a break.